So we're going to jump right in because we have a lot of information to cover. But my name is Anna Nall, and I am the Director of Transformation Freedom Initiative, or TFI, where we work to empower against exploitation by raising awareness and prevention of human trafficking. And we mainly focus our work in Central Virginia and the Shenandoah Valley, but we'll also do trainings like this one from time to time, and I'm honored to be here today. But a lot of how we do our work is by providing resources like today's training within specific contexts. So we'll have audience-specific presentations like for parents on how to parent their children and monitor online activity to prevent trafficking for their children, or we'll have occupation-specific training like this one. And we also do a lot of youth programs on prevention and safety and youth worker training. And today, I am a messenger of a training from a colleague of mine who works for Global Centurion. Her name is Laura Lederer, and she has done research on the overlap between health and human trafficking. And from that research, created this presentation that helps healthcare workers be able to identify and respond to human trafficking, because often when trafficking presents itself, it can be difficult to know exactly what you're looking at. So it's helpful to just have some of those practical tips. Now, I do want to say before we jump in that there are a lot of difficult topics being discussed in today's training, a lot on trauma and victimization, and that can cause us to feel trauma as well. There can be a lot of triggers, whether we've experienced trauma that I discuss or something similar. So I just want to encourage self-care during this time and do what you need to do to engage this well, but to also take care of yourself. With that being said, I do want to give you a little background on Laura, who again is the creator of this training and has graciously involved me in her work and taken me through her research so that I can also give this training to audiences and reach as many people as we can. But to give you some background on Laura, I want to give you a brief overview of her bio. So Laura founded and directed the Protection Project at Harvard University's John F. Kennedy School of Government in 1997. From 2001 to 2009, Laura served as the senior advisor on trafficking in persons in the U.S. Department of State. She also served as the executive director of the Senior Policy Operating Group on Trafficking in Persons. And she was part of the high-level policy group that staffed the president's cabinet-level interagency task force on trafficking in persons. She has worked as a subject matter expert for the U.S. Department of Defense, designing trainings like this one, as well as trainings on trafficking for the military and data collections instruments that are used to track DoD-related trafficking cases. And as a subject matter expert for the U.S. Department of Health and Human Services to help integrate human trafficking into runaway and homeless youth programs. She also designed and conducted the first retrospective study of health consequences of human trafficking, which you're going to get a sneak peek at today. Now, as we go through our agenda, I just want you to know that you have the Q&A feature and the chat feature available. We'll go over some Q&A at the end of our presentation, but there are a few times that I'll ask you to interact through the chat feature as well. But overall, what we want to walk away from today is being able to define and describe human trafficking in the United States, being able to understand human trafficking and the general health implications that come with it, identifying those environmental indicators, identifying individuals who may be experiencing trafficking. And then once that happens, being able to use a trauma-informed and person-centered approach, being able to assess the unique needs of a trafficking victim, to offer services based on those needs, but also be able to offer referrals. And then we're going to look at some of the laws that we have in place, both federally and statewide, that are good to be aware of when it comes to health and human trafficking. And to start, we have to look at how human trafficking is defined, because there are many myths and misconceptions surrounding this issue. But to do this, I want to have a little myth or fact activity with you guys and see how much you all already know about this issue. So I'm going to ask you all some questions, and in the chat feature, if you can just say whether you think the statement or question is a myth or fact about trafficking. So first, is it a myth or fact that all human trafficking is sex trafficking? See, we've got one person saying myth. Okay, a couple more people saying myth. Any other thoughts? Okay, good. Yes, so this is a myth. Very good. You guys are already on it. So experts actually believe that labor trafficking is more prevalent than sex trafficking, but we tend to have more awareness of sex trafficking, especially in the US. And this is something we often find when we talk about human trafficking, is where it's tempting to say, oh, numbers are rising in sex trafficking or labor trafficking, or numbers are rising in victims here or there. Sometimes it's not so much that the numbers are going up, but that our awareness is going up. And so we're seeing more of the victimization occurring. So next, is it a myth or fact that men and boys are also victimized by sex traffickers? See, yeah, we got one for fact, two for fact. Any other thoughts? All right, very good, you guys. So this is a fact. And an organization called Love 146 that serves trafficking victims says here that when they have adjusted their perspectives and programs to make space for and care for sexually exploited boys, they also saw identification rates jump, similar to what I just discussed on how when awareness goes up, we often see the numbers go up. So next, human trafficking is always or usually a violent crime. Myth or fact? All right. Yep. We got a couple for myth, which again is true. Very good. So this is one of the most pervasive myths about human trafficking, is that it involves kidnapping or physically forcing someone into a situation. But traffickers will often use psychological means like tricking, defrauding, manipulating, or threatening victims. Because when someone is under our mental control and has psychological trauma, it's much easier to control them than forcing them into a situation. And we'll talk more about force moving forward, but we have to be really careful about this, because while kidnapping and force can happen, it's not the most common. It is more fraud and coercion and manipulation that occurs. But we have been trained to think of force more, like through movies like Taken and other things we see about trafficking in general that tie into this force narrative. So next question I want to ask you guys is this: is human trafficking is not the same as human smuggling? Is that a myth or a fact? Right, good. We've got some answers coming in that it is indeed a fact. So human trafficking and smuggling are often confused. Smuggling involves illegal border crossings, and sometimes this can turn into human trafficking. But the crime of human trafficking doesn't require movement at all. Someone might be recruited and trafficked in their hometown or even their own homes. I tell parents a lot, if your kids have access to a device like a phone or a computer that they're on without a lot of supervision, sometimes they can be trafficked from their own bedroom without us really realizing it's happened. So it can happen in a lot of different ways and circumstances and does not require that movement. And then next, traffickers target victims they don't know. Myth or fact? All right, that is right. This is a myth as well. So it's often through a grooming process that trafficking occurs. And so we see that, traffickers. There we go. My PowerPoint decided to cut out for a second, but many survivors are trafficked by people they know. And this could be someone they know intimately, like a spouse or a family member, but it can also be someone who gets to know them. Like I said, there can be a grooming process. And so it's not always that a trafficker knows their victim when they decide to target them, but they will create a relationship to build that trust so that once exploitation occurs, it might be that a victim doesn't even realize they're being victimized because this is their boyfriend or girlfriend or a close friend or a business partner. So it can get really confusing really quickly. But now that we know a little bit about what is and is not trafficking, I want to go over what trafficking actually is, according to the Trafficking Victims Protection Act. So human trafficking is sex trafficking, where commercial sex is induced by force, fraud, or coercion, or where the person induced to perform such an act is not yet 18 years old. And it can also be the recruitment, harboring, transportation, provision, or obtaining of a person for labor services, again, using force, fraud, or coercion. And this can be subjection to involuntary servitude, peonage, debt bondage, or slavery. And this definition can be further understood through what's called the AMP, or Action Means Purpose model. So for trafficking to occur, you have to have an action like recruiting, harboring, transporting, providing, obtaining, in the case of sex trafficking, soliciting or advertising someone through those means of force, fraud, or coercion for the purpose of sexual exploitation or forced labor. And again, we see far more often than force, which does happen, that it's fraud or coercion. It could be a fake job opportunity. It could be a relationship that was only built to exploit. It could be someone saying, oh, you have this dream, whether it's a big glamorous dream to be a model or a dream to get a certain degree. I can help make that happen. But traffickers only making promises in order to exploit the person. And over time, it usually turns into that coercion element of blackmail and threats to maintain control. But you'll see here that there is an exception to the definition of trafficking when it comes to commercial sex involving minors. And we'll go over that in a moment. But I want to first look at what are the two types of trafficking that we see in the US, which are forced labor and sex trafficking. And forced labor, which also is referred to as labor trafficking, is understood through the AMP model as well. You have those actions of recruiting, harboring, transporting, et cetera, through the means of force, fraud, or coercion. And examples of coercion when talking about forced labor can be many things. It can be threats of force. It can be debt manipulation. Often traffickers will say, I got you this job or I got you this opportunity and now you owe me. But what's owed far outweighs what was ever given. It could be withholding of pay, taking away someone's ID. When you don't have your passport or driver's license, it can be really difficult to get away and start again because you can't prove who you are without that. Psychological coercion, it could be harm of reputation. If someone has an addiction, or a trafficker might get someone addicted to a substance and then manipulate that to maintain control, and then threatening those that the victim loves. And all of this, again, is done with that purpose to secure those labor or services. And there's no limit to the location or type of industry where this occurs. Traffickers can commit this crime in any sector or setting, both legal and illicit. And some examples of these settings include, but aren't limited to, agricultural fields, factories, restaurants, hotels, massage parlors, retail, fishing vessels, mines. It could happen in private homes, like through a maid or a nanny, and drug trafficking operations. But again, all three elements of that AMP model have to be present to constitute the crime of forced labor. And because forced labor is not a type of trafficking that is always discussed in depth, I want to go through two examples of how this can look to give us a fuller picture of labor trafficking. And these are domestic servitude and forced child labor. And in domestic servitude, this is when a trafficker is having a victim work in a private residence, which creates, of course, unique vulnerabilities. Domestic workers are often isolated. They might work alone in the house, and their employer will often control their access to food, transportation, and housing. And what happens in a private residence is hidden from the rest of the world, including law enforcement and labor inspectors, which creates these barriers to victim identification. And foreign domestic workers are particularly vulnerable to this type of abuse due to language and cultural barriers or having a lack of community ties. And this is when perpetrators will use these types of conditions as part of their coercive scheme to compel the labor of a domestic worker, knowing that there is going to be little risk of detection. When we talk about forced child labor, we're describing traffickers compelling children to work. And traffickers will often target children because by being a child, you are inherently more vulnerable. While some children can legally engage in certain forms of work, forcing or coercing children does remain illegal. With that in mind, though, practices like the sale of children, forced or compulsory child labor, debt bondage, and serfdom of children continue to exist despite legal prohibitions and widespread condemnation. And some indicators that a child might be forced to work can include a child being in the custody of a non-family member, or someone whose work is financially benefiting someone outside of the child's family. The child might be denied food or rest or schooling. So those can be some of the little hints that let us know that something's not right, and it could point to forced child labor. And the second type of trafficking we see most commonly in the US is sex trafficking, again, understood through that action means purpose framework. And the trafficker acts in the ways we described, as well as patronizing or soliciting someone to engage in commercial sex using that force, fraud, or coercion. Again, we exclude child sex trafficking cases when talking about force, fraud, or coercion, which I will go over in a moment. But sex trafficking occurs through coercive methods like serious harm being threatened, psychosocial harm, reputational harm, like, oh, what will your family or friends think of you if you tell them? It could be threats to those family or friends, and also debt manipulation can occur here as well. All of this to obtain that purpose of engaging in a commercial sex act. Like labor trafficking, sex trafficking can take place in multiple settings. This could be private homes, massage parlors, hotels, brothels, the internet, which indicates that for sex trafficking to occur, there doesn't even have to be intercourse or physical contact with a victim. This could be done through explicit messages, videos, pictures, but still has a very similar trauma effect on a victim. Now, as I've been promising, there is a distinction when we talk about child sex trafficking in defining trafficking. And that is because it has to do with one of the myths that comes up a lot in trafficking. And I want to ask you, you can put your answer in the chat again, but has anyone here heard the term a child prostitute? I've heard that term, child prostitute. Yeah, we've had some people hear that term. Yeah, and it's really important to talk about that here because there is actually no such thing as a child prostitute. When we define child sex trafficking, this is looking at how the means of trafficking, that force, fraud, or coercion, are actually irrelevant. So if a child is willingly engaging in commercial sex, then they are considered by law to be a victim. And that, this can be really hard to wrap our brains around, right? Like, okay, a child choosing to engage in this. But I had a survivor point out in a really helpful way once that if you have a child choosing to engage in a commercial sex act, you have to think about what made them feel like that is their best choice. And so I think it's really important to kind of stay here for a moment and think about this, because just like a child sex abuse victim, a child might willingly engage in a sex act with someone, but they, by law, can't give that consent. And the same thing applies to child sex trafficking, and is something that can seem obvious when we talk about it, but a lot of people can have trouble understanding, like, well, who am I to get involved if they're choosing this? And again, if it's a child, it is law to get involved. It's law to report and to understand that they aren't a willing participant necessarily when we look at the legislation. So really good to look at this, and also to discuss this in terms of prostitution and the fact that many prostitutes have a history of abuse and have a history of exploitation. And so talking about choice in these different situations can get less clear than we might want to think. And so just good to keep in mind as you continue to explore this topic of human trafficking and how it relates to your work. But those are our two types of trafficking that we mainly see in the US. So who is experiencing this? We know that victims of trafficking can be any age, race, ethnicity, nationality, gender, sexual orientation. However, we also see that some populations disproportionately experience trafficking, which is important to cover. You can see here a lot of examples that if we were to go through each of these, we could pick out something that makes someone vulnerable, that a trafficker will come along and exploit that specific vulnerability. So for example, you see here boys and men can sometimes be put more at risk, and that is because of that stigma of boys and men being victimized sexually. You also see like substance use and other disorders that go with that. If you have an addiction, often traffickers will become their victim's supplier to keep them in their control. And we're also seeing that an additional risk factor are adverse childhood experiences. When we experience abuse and other types of trauma from a young age, it becomes normal and we become desensitized to the way that we might be treated by someone. I want to give a quick example of this. I used to work at a Boys and Girls Club in my hometown. And I was recently meeting with my old boss from that Boys and Girls Club. She had been the unit director there. And we were talking about this concept of ACEs and how they make someone more vulnerable. And she shared with me a time where she was getting ready to let the kids into after school, and they were all standing in line outside the door. And she saw this third grade boy and second grade girl standing with each other, who apparently they had just become boyfriend and girlfriend. And she was just watching them, and she noticed that the boy started to just kick the girl in the leg, and the girl just had no response to it. And, you know, of course, this concerned her. So she pulled them aside and talked to them each separately. And when she talked to the young girl and was like, you know, when he was kicking you, like, you didn't seem to be bothered by that. Like, do you want to tell me about that? And the young girl said, well, I mean, my mom's boyfriend hits her. And so this was just a clear example of when we are exposed to a behavior, it becomes what we're used to. And so this can create vulnerabilities to how we're treated later on. With that in mind, though, I really want to encourage you not to put on blinders when it comes to vulnerabilities that lead to trafficking. It can be someone with a really wonderful home life who can end up trafficked just through the vulnerability of being unaware of this issue, or through an insecurity that a trafficker preys on. So want to be careful not to conjure up an image of a victim or a trafficker. So now that we have a little background on trafficking, I want to start to look at, okay, how does this overlap with your work as healthcare professionals? And to start, I want to go through a survivor story that highlights the 3 I's that occur when it comes to health and human trafficking. And these I's are injuries, illnesses, and impairments. So this victim shared that when I turned 13, I'd had enough of the abuse in my home and I ran away. I didn't know where to go, so I went to the center of town and stood by town hall. A man saw me hanging around there, and he said that he was looking for a protege. I didn't know what that was, but it sounded fine to me. He said that I could stay at his house, but when we got to his house, he pulled out a bottle of gin and had me drink. And the next thing I remember is waking up all sick and wet and hurt. The next day, he took me out on the street and told me what I had to do. When I said I didn't want to, he threatened me with a gun and pistol whipped me. And that's how I got into this life and couldn't get out. Over the next year, he hit me, punched me, kicked me, beat me, slashed me with a razor. I'd forced unprotected sex with customers, got pregnant twice, and had 2 abortions. I have so many injuries and so many illnesses. I have hepatitis C and STDs, stomach problems, and back pain. I overdosed on drugs twice and was taken to the hospital where they saved me, but then released me back to my trafficker and back to my pimp again. So I want to ask you here, is this victim story unique? Yeah, exactly. This victim story is not unique, which is highlighted even further in the research that I referenced earlier from Laura on the health consequences of human trafficking. And this research was conducted through survivors being asked to report on 200 discrete physical and mental health conditions. And this was gathered through a series of open-ended questions, like whether a victim had sought healthcare from a provider while being trafficked, what types of facilities survivors visited when they needed medical treatment, and whether a healthcare provider knew or asked about a survivor's situation. And from this data, I want to show you an example of 2 of the 4 survey pages that were used to collect this information. Over 300 survivors were interviewed and completed these surveys over a 2-year period. And the survey, as you can see here, asked a lot of questions categorized by body systems, which were neurological, gastrointestinal, respiratory, cardiovascular, reproductive, and more. And it also covered a basic set of psychological symptoms and diagnoses. It asked about violence and injuries from violence during trafficking, about substance use and abuse, including overdose, and then asked the question about whether healthcare was sought while being trafficked. And once this information was gathered, it was found that 87.8% of victims reported that they did have contact with a healthcare provider while being trafficked. 95.1% of victims reported experiencing at least some form of violence or abuse. 71.2% of victims reported at least one pregnancy while they were being trafficked. And from all of this information, we narrowed down what healthcare providers really need to be able to do when it comes to health and human trafficking, which is to identify, work with others, and connect. So to identify individuals who are being trafficked in order to respond appropriately through treatment and referring and reporting, to work with others in your health field to develop your best practices and programs and protocols. A lot of today's training can be kind of general for the healthcare setting, but the hope is that you can take this and fold it into your own practices and settings and translate it to your own staff and get them trained as well, which is part of that working with others. And then connecting with first responders and service providers in your community who work with victims and survivors to create that referral network and that community base to meet all of the multidisciplinary needs that a victim may come forward with. And just as a side note, it's important to keep in mind that, okay, services sought by trafficking victims, it is found through research are the services that you provide. So a lot of victims have the same healthcare needs that are being provided, especially in like the clinic setting and other similar settings, but it can be really any healthcare facility that you might see this. And then the populations that are vulnerable to trafficking, this is not an exhaustive list here, but just some of those populations are often served by healthcare providers as well, because anyone and everyone needs healthcare treatment, right? So we're going to see this overlap inevitably. And so your job here is just to really work on, okay, how do we identify these populations while looking upstream to prevent instances of trafficking? Now, I don't want you to get overwhelmed by this slide. This is a lot of different examples of red flags for trafficking, and we're not going to go into each and every one. But as you can see, there are different red flags that might come up through someone's actual physical presentation, their behavior, the environment that they describe that they're in. And each of these red flags might present in different ways at different points in a healthcare visit. So I just want you to be aware of how many different red flags can be present, and to also think about, okay, how can this look when a patient comes into your office or your practice? So I'm going to take us through the different steps of a healthcare visit and what each healthcare worker might see. And I'm talking scheduler, receptionist, intake staff, nurse, doctor, everyone and anyone, because everyone in your office has a role to play in identifying a trafficking victim. Before getting into those specifics, though, I do want to look at a case study for a moment and consider this scenario, which is based on an actual case. A young woman comes to the clinic and she is clearly distraught. She says that she thinks she is pregnant and asks for a pregnancy test. Upon examination after the test, the doctor finds severe bruises around her abdomen, and she confesses that her partner is unhappy about the pregnancy but does not want to say more. And while this young woman does not say so, her trafficker had beaten her around the stomach when he discovered that she was pregnant. We go over this to really highlight that often when uncovering cases of trafficking, it will be a lot more about what you observe and see than maybe what is said to you. So really important to keep in mind as we start looking at indicators. But as I said, it can really start at the very first contact with a victim. You might start to see red flags while making the appointment over the phone. So, for example, you might realize that the person that you're speaking to or your receptionist is speaking to is not the patient, or there are a lot of pauses and chatter in the background where you realize, oh, they're waiting for someone else to answer for them or give them an answer. And sometimes the victim might just pass the phone to the person to give the answers required to your questions as a scheduler. But when talking about why the victim wants to make an appointment, those can also bring up indicators. So it could be requesting STI testing. It could even be requesting pregnancy testing or having abortion-minded concerns. We talk about pregnancy or abortion concerns because research is showing that multiple abortions or forced abortion is an indicator of trafficking now. They might have requests for contraception, especially if you're realizing they're asking for multiple kinds of contraception or a large number of condoms. You might hear them talk about anogenital complaints, acute sexual assault, or disclosure of injuries from an assault or domestic violence or partner abuse. You might also realize that, okay, this person I'm speaking to doesn't speak English fluently. And in that case, you want to ask what the language requirement is. And if you can, let the patient know that you'll provide an interpreter for free. This is something that I encourage providers to look at having available because you don't want the person who comes in with the patient to be the translator, as sometimes things get lost in the medical lingo, but also if this person is their trafficker, they're not going to be translating accurately. And if you do have interpreters available, it's really important that they also receive training on trafficking because they might pick up on nuances through translation that you wouldn't. But at this point in the process, what's important is for the scheduler not to be too assertive or judgmental, because your goal is to get the patient to keep their appointment. You want to get them in the office so you can assess further. Now, once a patient first comes into the office and is at reception, this is where more red flags might occur. So you might realize that someone doesn't have identification documents. Like we talked about earlier, traffickers will take this to maintain control, or they might be escorted by someone who is carrying their ID. And if they're escorted by someone, it might be clear that that person is answering for the patient, or the patient is confirming their responses with their escort. And if a patient gives a wrong answer, you might realize they look really concerned about that. The person accompanying the patient might fill out their paperwork for them. And you might realize that you're not able to get any direct interaction with the patient. Like they won't even look at you because they're taught not to interact. It might also be that a client just doesn't have a stable physical address because they're moving around a lot. They might be disoriented or unable to identify certain basic things like where they are or family and friends. You might realize that they're dressed inappropriately for the season or place. The person with them, who might appear to be like a boyfriend or girlfriend, might not be age appropriate. And of course, signs of physical abuse. It could also be signs of self-harm that you see, or just clearly being fearful, agitated, angry, and other hyper emotions. And similar to this, you might see that the patient is just really fidgety or high strung, which could be signs of nervousness or addiction. Something I want to highlight before moving on to the next part of the healthcare visit is also that the person accompanying a patient might come in multiple times with multiple patients. And this could be the trafficker bringing multiple victims in. You might also see a girl bringing in multiple patients. Could be a situation of what's called a bottom girl, who is someone who has been trafficked or exploited and moved up in the ranks, so to speak, to often protect themselves from exploitation, and are now have responsibilities of overseeing other victims. And for labor trafficking victims, you might also see some different signs that aren't as obvious, like just signs that they've been exposed to chemicals or other hazardous working conditions, like pesticides. Now, if you're seeing indicators, whether you're on the phone scheduling with a patient or they're at your desk in reception, you want to notify the next person who's going to engage with the patient. So if you've scheduled the patient, you know who's working reception when they come in, you want to tell that receptionist. If you're the receptionist, you want to tell the person taking the patient back to the exam room, just so everyone's on the same page and can be aware and alert to looking for further indicators. Which then brings us to some indicators that can come up during medical history and exam. And during this time, it's really important to have protocols in place that can help identify victims. Like, you might have a protocol to examine the patient alone. Providers could say, this is because of confidentiality or privacy. But if a client is insistent that they're, the person with them comes in, or the person who's with them says they're going to leave if they can't come in with the victim, then it might be necessary to bend that rule so you can gather as much information as possible. But during the exam, you might see a lot of different red flags, during the taking of the medical history, like multiple sex partners, unintended pregnancies, miscarriages, abortions, STIs. They might talk about the types of contraception they use being used simultaneously or serially, a lot of uses of the morning after pill, uses of misoprostol, talking about a lot of UTIs, history of substance abuse or homelessness. And then when actually examining the patient, you are going to see those signs of physical abuse or injuries. You might see specific tattoo markings or needle tracks from addiction, gynecological complications. You might even see foreign objects in the vagina. Someone might be experiencing really serious diseases like hepatitis or TB, or dermatological issues like scabies or lice. This can occur both in labor and sex trafficking due to living conditions, just malnutrition, being dehydrated. They might have some suicidal ideations or attempts that they talk about, and you might see those signs of self-harm as well. And during this time, what's critical is for the healthcare provider to be demonstrating that care, compassion, and consistency that is used in a trauma-informed approach, because a trafficking victim is going to have complex trauma that even a simple exam could trigger. So you might experience a patient having fear or flashbacks or other trauma reactions that don't make sense if you don't have this kind of information. And you also want to just be very approachable, use simple language. Many victims have had disruptions in formal education, so you want to ask clear and concise questions to uncover trafficking. And you also want to be sensitive. Some traffickers have said, I don't know how many sex partners I've had. And so you might reframe a question to say, have you had more than this many sexual partners in the past week or month? So creating a threshold can be helpful. And your goal is just building that trust and making a victim feel safe enough where they could disclose what's happening to them. Which probably begs the question of, why don't victims seek help from a healthcare provider? You're thinking, I know the signs, but why don't they just tell me what's going on? And the reason for this has to do with victim-related barriers as well as provider-related barriers. For victims, it's difficult to disclose at times because of fear, lack of knowledge, and trauma. Fear can include just being fearful of authority figures in general, which can include doctors or clinicians. A trafficker has probably threatened them about telling. If they've been brought here to work illegally, they might fear deportation or law enforcement. And sometimes it could be fear that reporting could lead to the return to an abusive home. This can be a fear for runaways, or homeless patients who have escaped one abusive situation to find themselves being trafficked. And then, of course, threats to loved ones. Lack of knowledge includes not knowing that they're being victimized. This has to do with that grooming process that takes a real psychological toll. It could be a lack of understanding of legal rights, not having their ID or other records, or just those language barriers, or limited literacy from education that has been interrupted. And then trauma. Of course, there's going to be a lot of trust issues when someone's experienced trauma. And it's hard to build that trust with a patient, especially if they have a transitory style of life. They may have difficulty saying what's going on because they feel deep shame or guilt. Often victims are forced to commit the crimes of their trafficker. And so there can be some false guilt associated. They might have been traumatized in a previous healthcare encounter, might have a trauma bond with their trafficker, or just guilt about everything that they've been through. And for providers, there can also be some barriers that prevent disclosure, which can include knowledge, empathy, and time being lacked. And so just not having that knowledge of a trauma-informed approach can be a barrier. Not knowing a lot about trafficking or what it looks like, the laws with it. This can cause misdiagnosing a case. You might not have good referral options, which can hinder a victim really opening up, or you might fear violating HIPAA. Empathy can also come into play, which can be really subconscious and unintentional, but our body language, our tone of voice, and facial expressions, we might not be thinking about, but they might convey something that will shut a victim down. We might be experiencing unconscious bias. Some survivors have said, they felt judged because maybe they came to get care for a pregnancy and felt judged for being unmarried or unable to take care of their child, or questions that indicated that they were unfit to bring a pregnancy to term. You might feel that a patient is unresponsive because of their trauma, they're shutting down, or you might think they're lying. Often victims tell a script-like story that their trafficker has told them to say, or it could be that they're telling the truth and it doesn't seem to line up. Trauma can cause our timelines of events to become muddled. And so victims will often be accused of lying when really they're just trying to make sense of their story and everything that's happened. Having preconceived notions of how a victim will present can cause a barrier, not believing it's your role to get involved. And it can also just be practical things like not having the time with the patient you need, thinking it might be too time consuming, or just, trying to get through the day and see all your patients. And it can be the very strengths of a healthcare site that can be a barrier. Like you might have a policy to ask few questions and provide service without getting too invasive. But if you're realizing trafficking might be occurring, it's good to be flexible with those protocols and to decide, okay, I'm going to interact more with this client. I'm going to ask more questions and build that trust so I can see what's really going on. So how do we overcome these barriers in a practical way? And I want to take us through 4 practical responses that can help us create a safe environment for victims to disclose and also serve those victims. So having a victim-centered and trauma-informed care approach is crucial, as trauma is just a widespread and harmful, costly public health problem that has no boundaries to who it impacts. And any response to human trafficking has to have this approach so that the safety and well-being of the victim is the priority. In this approach, a victim's concerns and safety are the top priority in all procedures. This approach minimizes victim re-traumatization by seeking to provide support to the trauma or support to the victim. And this approach also takes a systemic focus on the needs and concerns of a victim to make sure that your response is compassionate and sensitive and serves them in the best way possible. In this approach, there are some do's and don'ts. You want to create that safe, trusting environment. And to do so, you have to, let the patient know who you are, what your role is in an exam, explain how you can help, be an active listener and empathize, ask open-ended questions, try and limit the number of people a victim has to talk to about their circumstances, as that can cause trauma. offer to connect the client to services, and then encourage return visits and follow-up. What you want to avoid is things like using derogatory names. This could be things like illegal alien, prostitute, or other labels that are incorrect or offensive. You want to be sure that you don't have that any kind of abrupt or dismissive manner, or that you're not making negative assumptions like thinking that they are involved in a criminal activity when maybe they're being trafficked. Pretty obvious, but you don't want to blame the victim for the crimes committed against them or pressure them to talk or say that what's happening is all in their head. So this approach does require a lot of patience and empathy and compassion, but it's really, really important. I want to take us through the scenario of how to really engage this approach. So say you are giving an exam and you find out that Sarah, a minor, is being sex trafficked by her stepfather. You're a mandated reporter, so we'll need to call law enforcement or child protective services. The police and CPS will have their list of steps they need to take, like interviewing Sarah, obtaining a sexual assault evidence kit, and determining a safety plan. Sarah says no to alerting authorities. So what would you do? In this case, you want to acknowledge and explore her reluctance, explain your reasons for alerting authorities and testing for sexual assault, listen and respond and strategize together. So you might respond by being like, okay, well, can you tell me a bit about why you don't want to alert authorities? I'd love to hear your thoughts. You might get a response like, well, there's no point. What's done is done. You could say, I understand that it doesn't make sense to go through the process, but there are some good reasons for these procedures. I'd love to talk a little bit more about it. To this, you might get some resistance of just like, just give me the test. I need to go. And you can just kind of probe a little deeper, be like, okay, let's just talk about it a little more. And you might get even more resistance at this point because Sarah's frightened. She wants to get back out there to her stepfather because he's probably upset, as you can see in that response. But here's where you want to involve the victim in what you have to do. So in this case, mandated reporting, right? You have to go through with it, but you can give Sarah control through choices. So you can say, Sarah, I do have to report this to authorities, but there are several ways we can do it. And then giving those options of, do you want to call them together? I can call them and then give the phone to you. We can both be on speakerphone. How would you choose? Now, another aspect of a victim-centered approach is remembering the 4 R's of trauma-informed care, which are realizing the widespread impact of trauma and understanding paths for recovery, recognizing the signs and symptoms of trauma, which can occur in patients, clients, families, staff, and others, responding by fully integrating knowledge about trauma into your policies, procedures, and practices, and then resisting re-traumatization. Now, I'm going to skip through this scenario so we can get to our next part of overcoming barriers, because I know we're coming up on our time here. But the next part is recognizing unconscious bias. And as you can see here, scientists are estimating that 80 to 90% of our minds work non-consciously, which when I figured that out or heard that, that was pretty frightening. So we have to be aware of this concept of unconscious bias and the quick snap judgments that we all make. And this is important to do because these biases are social stereotypes. Like the slide says, we come up with these stereotypes about groups of people or individuals that are formed outside of our conscious awareness. And it happens outside of our control, and our brain just makes a quick judgment. But it results in some damaging things like micro behaviors that send positive or negative messages. Those micro messages that can reveal our unconscious thought, and these can result in micro inequities, sometimes micro affirmations, but it can be pretty negative. And survivors have said, this has really impacted their care that they received. One survivor said they got a positive pregnancy test back, and instead of congratulating her, the staff just assumed she wouldn't want the baby or be capable of taking care of the baby. So to deal with unconscious bias, we really have to look at what's called the RAM model, which is recognize, address, and manage. So we want to become more aware of this phenomenon through training and examination and admission, seek opportunities to learn more about cultures that aren't familiar to us, engage others, and support diversity and inclusion events. You want to address this by assessing training needs for your staff on this issue, learning more about social stigmas that come with trafficking. And if you see unconscious bias, give give constructive feedback. And then manage, seek out positive images or stories on victims of trafficking, learn to really take that unconscious and make it conscious. And then again, create those opportunities for staff learning. One survivor said, host a survivor for a lunch and learn and ask about what was your experience in the healthcare setting. So lots of creative ways you can go about this. And I'm going to skip through this hypothetical scenario, but in this scenario, you basically have healthcare workers who make a very loud comment that is offensive to a patient. And the response here is to, pull those individuals aside separately. You don't want to shame them either, but let them know, hey, that's not the behavior that we have in this setting. We want our clients to feel like they are cared for and can trust us. And we want to remember that they may have been through something that we can't even imagine. So our next step in overcoming barriers to getting help is building trust and meeting needs, which happens at each stage in the healthcare visit, just like you might see red flags at each stage. But when you think about each stage of your client and what they might experience in your own healthcare setting or practice, this can help you create a human trafficking response plan and how the patient is experiencing you throughout the visit. Some practical tips is you can have information on human trafficking and the signs and indicators and reporting in posters in your waiting room or in your exam rooms and bathrooms. Some victims have seen that and it's helped educate them about their situation. But again, doing all of this to create that trusting environment. These are just examples of how you can interact with the client in a way that shows care and consideration. I really want to highlight how this can be done in the exam room to really seek true consent on letting someone know what an exam entails, walking them through that, and then asking permission to go forward with the exam. Because otherwise it can be really traumatizing if you just jump into an exam and a victim doesn't know what's going on, and there can be a trauma response that can be difficult for everyone. And then just understanding all the needs of a survivor can help you build trust, knowing there are lots of medical, psychological, physical, and social needs. And from that, realizing there are some needs that you won't be able to meet as a healthcare provider, which then leads us to understanding the importance of community connections. You want to be sure that you have referrals ready to go because you need that network to rely on to be able to set a victim up for success in getting shelter and care and practical needs like food and clothing. And you can create this network by just locating local services to your area. You can call the human trafficking hotline to identify those local services. And then you want to be proactive, call, introduce yourself, do your due diligence to make sure that organization is serving clients and victims in an ethical and true way, and then maintaining relationships with those organizations. You can also look into if there is a coalition or task force in your area that is already addressing human trafficking. You can join those coalitions or build your referral network that way. And then to practically refer someone, you want to practice what's called a warm handoff. So first, before that happens, you're going to think about everything you've learned about this patient and what resources that they might need. Empower the client to actively participate. As you see below, it might be saying like, hey, I have some ideas of ways you can seek care outside of my office, but do you want to hear those options? You're the expert of you. What do you think? And then if a client is interested in resources you have to offer, don't just send them home with the resource, because first of all, if a trafficker finds that on them, they could be hurt. But you want to, while they're in the office with you, make that call with them. Because when you do this, it's more likely that a client will follow up and they don't feel alone in the process. But if mandatory reporting is needed, keep in mind you have to make that report. And what you can do is just let the client know, hey, this is a situation where I have to report what we've talked about, but here are some options on how we can go about that. And this is a case study that goes over that as well. But lastly, you might think, oh, we only have 3 minutes. This is a really quick little section on just some laws and going over reporting these issues of trafficking within the medical record. But I just want you to be aware that the federal government continues to pass comprehensive legislation addressing human trafficking. Being a victim of sex trafficking is an affirmative defense to prostitution charges, which is really important. And healthcare providers are required to report incidences of human trafficking in minors, as well as suspected exploitation of victims over 60 years or who are mentally or physically disabled, which can bring up questions of, okay, where does HIPAA play into this? And so it's really great to understand that you all can report human trafficking without violating HIPAA if there's an imminent danger to the patient or the public, if the patient consents to disclosure, again, if you're mandated through other reasons like being a minor or disabled. But if they do not consent, there are some steps you can take. So you can't report if they don't consent, but you can provide the patient with information like the human trafficking hotline. Again, don't send them with like hard copy information, have them memorize it, make a follow-up appointment. You can call the human trafficking hotline for guidance without giving information that would violate HIPAA. You can call authorities and do the same thing and get guidance on, hey, I have the situation, but HIPAA, and see how far you can go without making that violation. And then documenting human trafficking in medical records is crucial. There are ICD-10 codes that I believe was sent to you all and will be sent to you all again in a follow-up email that are important for recording human trafficking in medical records. However, it's also important to realize that this information on trafficking can threaten a client's safety when a provider isn't trained in human trafficking, or they're using the diagnostic code for trafficking, but not providing referrals or other services. But another thing to keep in mind is making sure that how you record health information, however you keep your records, are protected. Because if there is any way that a trafficker or someone from the general public could access those client records, then you can't report it because that would put the victim at risk. So you want to make sure that your center has policies that protect data, train staff in managing that confidential information, and then train providers to communicate with clients about how and what information is recorded. For example, you do not want to record their story because that could be subpoenaed, and then a victim might have to go through the criminal justice system in a way that is more harmful than helpful. So you want to be sure you use the codes appropriately, and that if you use them, the information is 100% protected in your system and any systems that you share information with, because otherwise it will result in harm. But even though there are challenges to using these codes, I encourage you to find safe ways to do so because it will impact data that can help serve victims. Now, I know we're at time, so just to summarize, you all play a vital role in identifying and treating victims of trafficking. As you can see, this is everything that we've gone over. And so thank you for being a part of this training today because it really matters, and your response to possible victims really matters. I want to leave you with this survivor spotlight of a victim who said, you know, I was trafficked when I was a child, but trapped in it for years and had a violent pimp. I went to many emergency rooms and clinics and offices, and it seemed like my body was just to be poked and prodded and fixed. I remember going to a hospital after my pimp beat me and having a nurse put her hand on me. She just touched me as a person and said, it's going to be all right. And I'll never forget that response. This was the first time someone seemed to see me as a person. The nurse saw I was frightened and listened to me. And it was the first time I thought about telling someone what was actually happening to me. So everything you've learned today is going to help you to be able to respond appropriately to help save survivor lives. So again, thank you for your time. Here's some information on the human trafficking hotline where you can report suspected trafficking as well as get more information on trafficking. In Virginia, if you need to report trafficking, it's great to call the state police as well at #77. And for minors, it's important to call the Department of Social Services as well. This is my information if you want to connect outside of this webinar. And I know that we are at time, but if you have any questions, please feel free to email me or stay on a little longer. I'm gonna stay on and will be happy to answer any questions if you all if you all want to stick around. So thank you again.
Thank you so much, Anna. And just as an FYI to everyone, we will also be posting this on our website, and look out for an email from the government affairs team with the ICD-10 codes and another follow-up message. Appreciate you.
Thank you all so much for hosting. Oops, go back here in case anyone wants that information. Let's see if there is a Q&A section if anyone wants to put in questions, or you can also email me directly, but I'll stick around for a couple more minutes. Right, I don't see any questions, but again, feel free to contact me directly, and thank you all so much for the work you do and your time. Thank you, MSB and Taylor and Chris. I so appreciate you all.